was not any registered dietitians in this service because I'm speaking mostly today. The topic was to be diabetes management over the holidays. I almost put in there in parentheses also during COVID because I feel like this has been a huge impact on patients with being able to control their diet, with being at home and not, working from home and having a refrigerator very near and able to pop over and get into refrigerators and pantries and stuff like that. So it's diabetes management for the holidays. So this is predominantly a talk on weight loss and nutritional management. And so Janet, anytime you want to pop in and enlighten me, that would be perfectly fine as well. Next slide. So there are recommendations by the ADA, and nothing actually new has been updated since May of 2019. I expect moving forward in the next year, it's kind of, and I say nothing new, that's in regards to nutrition management. They are always coming out with changes and recommendations, and expect to see some more here again, actually moving forward with the vaccine and what is going to be recommended for diabetics at that point. But evidence that says there's not an ideal percentage of calories from carbohydrates or proteins or fats for all people with diabetes. So we like to think that there's a certain amount, but there is not an ideal percentage. This is also because we have to consider personal preferences. And that's what makes this hard and makes it individualized. So you not only have to consider what is your socioeconomic status, can you afford foods, but also culture, religious beliefs, can they eat meats? Are they having any health aspects that would limit them, such as end-stage renal disease, and they have to abide by that diet. So lots of things to consider what would be the best for them. So not necessarily a diet, but sometimes an eating pattern is also. So there are a variety of eating patterns that are acceptable in the management. And again, the ADA recommends a referral to a registered dietitian. Nutritionalist is essential in the outpatient and overall nutritional status. I'll talk about diets moving forward, and you can kind of see they talk about Mediterranean. That tends to be my favorite when people are asking, and that's just on personal preference of what I think patients can do. But we'll go over that and DASH and some plant-based, and just trying to get people to eat healthy. Research studies are on some low carbohydrate eating plans are indicated, but as it says here, long-term sustainability is the most important thing. So many people also, I kind of say, fall off the wagon in diabetes because you just get tired of being a diabetic. You get tired of following the nutritional rules and sometimes lose interest in it. So next slide. So along with guidelines, they come up with a consensus report, and this is also from 2019. And it's a consensus report is to help us with evidence-based guidance about anything. And so I'm choosing the aspect of nutrition for diabetes and pre-diabetes. Strong evidence supports the efficiency and cost effectiveness of nutritional therapies. I think that's key, that we do know that improving nutrition is a cost-effective way of managing diabetes. And I have this topic multiple times with people. I'm like, do you want to spend money in nutritional therapy and eating better foods, or do you want to put more money in insulin and be able to eat whatever you want? And I kind of say it callously, but that there's truth in it. If we could get people to modify their diets, then they would have some improvements and cost effectiveness and less medications necessarily to be used. So again, nutritional counseling that works towards improving or maintaining glycemic control. So that's the other part, that falling off the wagon, achieving weight management goals and improving cardiovascular risk factors, which is another huge aspect of diabetes, having hypertension and cholesterol issues. And we want to individualize these treatment plans. So medical nutritional therapy is fundamental in the overall diabetes plan, and it needs to be discussed and I'm going to go over the medical nutrition, what the recommendations are as far as how often to meet. It's in the next slide or two. Next one. So moving on, eating patterns. These three little bullet points are going to be the key take home of this. I'm going to go over different eating regimens and the studies that have been done, but evidence surrounding these health benefits of taking a specific individual eating type of eating isn't necessarily the best. That we as healthcare providers should focus on non-starchy vegetables. So, you know, corn, sure, it's a vegetable, but not really a good aspect or a good one to take. Other things like peppers, I think people don't realize these sweet peppers that are out, and your green and red and yellow peppers, they actually have a lot of carbs in them. I had a patient that it took us a while to figure out what was causing the spike, and it was peppers, and that was the evening snack, and ended up eating close to 20 and 25 grams of carbs just in sweet peppers. So emphasizing or minimizing, adding sugars and refined grains. So that's the sweets, and trying to keep those to a minimum, which most diabetics realize, but the ability to do it is another case. Choosing whole foods over highly processed foods to whatever is possible. So very surprising how many people will go to McDonald's. It's the dollar meal and the dollar hamburger, but it has a bun and your cheese in it and ketchup and mustard, and those all have carbohydrates in it. So it does add up, and it seems like they never leave without French fries. So those highly processed foods, we need to reduce them. Reducing overall carbohydrate for individuals with diabetes has demonstrated the most evidence for improving glycemic control. And so that's where these three things will, if we can get patients to do that, will improve hyperglycemia. So we also know, I had already said, not meeting glycemic targets or being able to reduce medications is a priority. Then, you know, trying to get patients to reduce their overall carbohydrate is a viable approach. And that's where a lot of pre-diabetes also, you know, when patients actually come to me, I don't get to see that pre-diabetic level. So you as family practice providers and primary care providers, you know, working hard on understanding those three top things have to be changed. It will keep them off of medications, maybe not forever, but maybe the next 3 to maybe even 10 years. So next slide. Dietary fiber. So many patients come to me and just say, well, if I put more fiber in my diet, I want to say the myth, it's actually true. A few studies have shown some modest A1C reduction. So that's very modest at 0.2% to 0.3%. And that is with taking in more fiber. And I know we talk about adding fiber and having whole grains and having, you know, whole wheat breads and, you know, brown rice versus white rice. Yes, that's great. And it does help. But they also still need to remember, if you eat 2 cups of rice, you still have had a lot of carbohydrates. So the fiber helps, but it is a modest reduction in A1C and blood sugar lowering. And most of the time, the amount of fiber that it takes ends up causing some gas issues and some diarrhea issues and bloating. So that's another aspect of it. So it's a good thing, but just don't let your patients get too caught up in the overall success of that. Next slide. What is the evidence for specific eating patterns to the management of type 2 diabetes? And this is where I kind of pulled about, I think there were 8 that they gave us on the consensus report, and I pulled, I think, 5. So Mediterranean has demonstrated a mixed effect on A1C, weight, and lipid. And those are most of the trials of what they're trying to do is just not A1C. They're always having some amount of weight loss in these reports and these trials, and also cholesterol levels. So it kind of gets lumped in there. But there was a direct trial where A1C was lowest in the low carb group after 2 years. And then the plasma glucose was lower in the Mediterranean style group. So they had 3 different groups, a low fat, a low cholesterol, and then Mediterranean. And they all had certain parts that was good. And therefore we have to kind of do the take home and say that they're all good, but there's nothing is majorly superior in this. There was another trial, again, it was called the PRED-IMED trial, and it was comparing the Mediterranean to a low fat. And this was one of the longest trials that are out there, and it was a 4-year trial. And they found that glucose lowering medications was able to happen. So actually get patients off of meds and decreasing in doses in the Mediterranean eating pattern. So that was a positivity about it. But in general, again, there's no superiority in it, and they all have certain aspects. Next slide. DASH. The DASH diet is more, this one is, I apologize for my typos here, but this one is promoted by the Heart, Lung, and Blood Institute, and it's more a prevention for hypertension. I have patients that come in and have hypertension and say, I'm on this type of diet. Is this still good for diabetes? And this diet is rich in fruits, so that's fine as far as being healthy, but you have to remember fruits have a lot of carbs. So it also is vegetables, whole grains, and low-fat dairy. So again, is it good? Sure. And in their one small trial in this DASH diet eating pattern with a controlled group, showed an improvement in A1C, blood pressure, and cholesterol, and weight loss with the DASH pattern, but no difference in triglycerides. So again, it's not a bad diet, and especially if cardiology is recommending it, I would definitely not poo-poo it or say, no, don't do this one. If they're able to do it, it has some good foods in it. We just have to watch those fruits. Next one. Vegan eating patterns. So again, this one showed mixed results on glycemia and cardiovascular risk factors. But what they did find, and it happens in several of these diets with low carb, that the eating patterns often result in weight loss. And we know weight loss will help reduce blood sugars and A1Cs. So with this one, they saw 0.3 to 0.4% in people with type 2 diabetes. So it is another eating pattern that certainly is possible to try and consider. Next one. Low fat. So this one was really related to weight loss. This was the look ahead trial, and what they found with low fat is just the weight loss is the part that helped control A1Cs and that type of thing. But this was more for lowering fat intake and didn't consistently improve A1Cs, but it was helping with the cardiovascular factors. So when caring for patients, you know, it's our side topic. So we talk all about nutrition and diabetes for our patients and, you know, low carb, but then we know our cardiovascular risk factor is hypercholesterolemia, and getting them on statins, but also then kind of putting in that comment, well, it also needs to be low fat. And then the next comment you get is, I can't eat anything. And that unfortunately isn't true. Then you need to talk about moderation. But low fat is always promoted by me as well, because we can't forget about the risk factors of stroke and heart attack with diabetes. Next slide. Paleo diet. I don't know, maybe 2 years ago, I actually had to look this diet up because I'm like, what does this mean? And found a little bit more about it. It's a Stone Age diet. And it's a modern fad diet that consists of foods thought to mimic or mirror foods eaten in the Paleolithic era. So this is all the lean meats and fishes and fruits and vegetables, nuts and seeds. So to me, it's just a healthy diet. But people like to call it paleo, and there's not any significant long studies have been done on this. And then again, the mixed findings on loss of weight and improvement in cholesterol and A1C. But if you look at what it includes, sure, our diabetics can certainly do this. Next slide. Intermittent fasting. This diet drives me crazy. Lots of patients are about it. And honestly, in type 2, I say if you want to try it, that's perfectly fine. And the issue is doing this and also insulin use. So type 1s, I really don't promote it and try to tell them to very short periods of fasting. So maybe 9 p.m. to 9 or 8 a.m. And that's basically 12 hours, which anyone could and should be able to do on a regular basis. So it's not really that acceptable for type 1. And we even talk about safety of intermittent fasting with people with special health conditions. And the bottom of the slide, it says include pregnancies and disorders, eating disorders. But I think they should also have in here type 1 diabetics. So type 2s, though, they have shown some improvement. And again, this is a weight loss effort. So it's a lot of times not sustainable for people to continue to try this. It's more to lose weight kind of quick. And then we even saw that the improvement in A1Cs, there was no improvement in A1Cs in one of the short studies at the beginning. Kind of see where I have it highlighted there. They did try to say it improves sensitivity, but again, that's weight loss. If you insulin sensitivity, if you lose weight, you have less resistance. So of course it's going to improve it. It's going to improve beta cell responsiveness. And so these types of diets are out there. As far as you're not going, without food or drink for anywhere between 12 and 16 hours. And then you have those periods of times of days where you are allowed to eat. And again, intermittent fasting is not about what you eat. It's about how long you're allowed to eat. So I caution my diabetics on this too. So they can't just not eat for 16, 18 hours and then just gorge on sugar foods and high carbohydrates and starchy foods during those period of times, because that's just going to set up for hyperglycemia all during those 8-hour periods of time. So this is definitely a fad. And in the right cases, I'm not going to say it can't be utilized, but I think it's the diet we have to be most cautious with our patients to prevent hyperglycemia when they're actually eating, and also hypoglycemia when they're not eating, if they're on medications such as insulin or a sulfonylurea. Okay, next slide. So this goes back to, which kind of, I don't want to say, when I was going through the consensus report, they basically put another paragraph back in the consensus report after, is there evidence that supports a specific eating pattern? And I've already told you that it doesn't. There is no evidence. And we go back to those 3 key points that we talked about at the beginning: non-starchy vegetables, minimizing sugars and refined grains, remembering that includes fruits in this area, not just your sweet foods, but also your fruits. We would much rather I would rather than have an apple instead of a piece of cake, because of caloric intake. The apple is going to have 20 grams of carbs. And maybe your piece of cake also has 20 grams of carbs, but the overall caloric intake is way different for 80 calories for an apple versus 300 calories for a piece of cake. So those sugars also include fruit, and choose whole foods, choose foods that are not highly processed as best as possible. Okay, so these no single eating pattern has emerged as being clearly superior to all others for diabetes-related outcomes. And evidence suggests certain eating patterns are better for specific outcomes. So that's when you can kind of say maybe like the fat lowering would be great because you're trying to do cholesterol. But overall diabetes management is more about healthy eating, portion control, than it is about a specific one diet fits all. Next slide. So as I had said, there's when you're talking about diets, weight loss is kind of universal. It comes in there, and we know that if we lose weight to support weight loss and improved A1C, cardiovascular risk factors, and quality of life in adults that are overweight and pre-diabetic, medical nutrition therapy and diabetes self-management education services should be included in individualized eating plans in a format that results in an energy deficient in combination with enhanced physical activity. So basically diet and exercise. Also remember, we've talked about, and I've said it already once, that health literacy sometimes plays a part in this. Older patients that have prone to hypoglycemia, emphasizing weight and portion control and healthy eating needs to be considered. People come to me a lot and say, how much weight do I need to lose? The consensus report gives you some guidance to be able to tell patients what to do. So optimal outcome is 15%. When this can be done, and in pre-diabetes, 7 to 10% of weight loss will help prevent the progression of diabetes. So 5% is recommended to achieve clinical benefits in general, but more like 15% for changing your medications. All right. Overall healthy eating plans that result in energy deficient in conjunction with weight loss and metabolic surgery could be considered to help achieve weight loss and maintain goals. So it is something that we can offer our patients. I have 2 in the hospital right now that have had sleeves and has been done for diabetes management. So I have a couple outpatients that have been highly successful with surgery and coming off of numerous meds. The longer patients have been diabetic and then choose to go to weight loss, so they've had diabetes for 10 years and they're already on insulin, will the surgery be successful? Yes, in the fact that likely a decrease in medication and therapies, but probably not gone. And we also need to remember, in general, diabetes can kind of go in remissions, but it's not gone. It's always going to need to be controlled through diet and exercise when they're off of medication. So again, I talked about this already. Pre-diabetes, a healthy weight should be considered in order of prevention of the progression of it, involving aerobic and anaerobic exercise. And again, it brings up that Mediterranean diet. Next slide. So how can we get weight loss? If they're already a diabetic, they can have up to 3 to 6 medical nutrition encounters during the first 6 months following the diagnosis. Unfortunately, most of my patients, I'm not diagnosing them. So this would be the primary health care providers making sure they are offering these and getting the patients to it. Most time it's not that we don't offer, it's that patients don't go. A lot of times they're worried about cost and what is going to be covered. So then they are permitted to have a once a year annual follow-up with medical nutrition therapy. And that's most of the time where I am. I'm trying to encourage them to go back. I think patients think they kind of always know it all, but I kind of always encourage that, someone else looking at your lifestyle and what you eat and what you don't like, and having a different person bring it up and talk to you in a different manner. Hopefully you can learn something that you can change to help improve. So that's why it's good to do, this once a year follow-up. It's not that they might necessarily learn something overall new, but something new that they could change in their diet that they hadn't thought about. Next slide. So this is, again, just trying to prove to you the points of weight loss, putting diabetes into remission. And there was a look-ahead trial that compared a control group. This one was a lifestyle arm, resulted in partial diabetes remission compared to the controlled group. So they had like 11% remission compared to a 2%. There was another trial called the direct trial that showed at 1 year weight loss associated with lifestyle interventions resulted in diabetes remission by 46%. So just trying to instill that weight loss is goal, and weight loss is mostly through nutritional therapy. So even our patients that can't exercise or say my knees hurt or my this hurts, working on that change in diet for weight loss is where they're going to get it. Next slide. So I talked about this last year, a little bit about sweeteners and the use of them. So I have patients that come in and drink 3 sodas a day, or sweet tea, 6 of them a day. And patients in my own personal treatment, I've seen when they cut those out that they can literally change their A1C by not a 0.%, but by 1 to 2%. So an A1C of 8 down to 6 when they just get rid of sugar sweetened beverages. So kind of investigating, when do you drink them? How much do you drink them? Do you drink them over the entire day? Do you just drink one with lunch and then your blood sugars go high prior to dinner because you ate a soda at lunch? So the goal and recommendations is to replace those with water as often as possible. And then, yes, you should be using sugar substitutes as well. And this is a crutch sometimes for people because they'll order soda at McDonald's, but then they still get the French fries. So they feel like they can, kind of give up. And I guess if you're not a diabetic, that's an okay thing to do because you are decreasing caloric intake. And if you decrease caloric intake, then you're not gaining as much weight. But patients tend to take a sugary or a sweetener so that they can then eat more of something else later. And so watching that aspect and making sure it doesn't happen as much. So know that potential adverse effects from sugar substitutes, sometimes many reports have said altering the feeling of hunger and fullness. So it doesn't help with that. Then again, what I had talked about is substituting these sugar-free substitutes for healthier foods, and also then not having healthier foods, but then also choosing something that's also high in calories. So we should be, in general, just trying to overall reduce our sugar-sweetened beverages with water as much as possible. And then, yes, we should be promoting sugar-free popsicles and sugar-free Jell-O and some sugar-free cookies. But sometimes that doesn't help with hunger aspects. Those sweeteners can make them actually more hungry. And then sometimes in turn, they do this so that they can eat something else. So it needs to be this and continued decrease in carbohydrates. Next slide. Because it's the holidays, not only are we eating more sweets, but alcohol consumption tends to go on more during holidays and special times. So it is recommended that adults with diabetes and prediabetes who drink alcohol do so in moderation. That's a given, and it gives you that 1 drink per day for an adult, 2 drinks or less for adult men. Educating people about signs and symptoms of hypoglycemia that can go on from alcohol intake, and it's a delayed hypoglycemia. So sometimes it's 6 hours after they actually ingested alcohol. This happens most often, to be honest, with just the insulin or sulfonylurea drugs most often, but in general, making sure that patients are aware of alcohol changing their cognition, so then they don't think about eating, or they go to bed without taking their insulin, or they go to bed without taking their meds. So, that's obviously not 1 drink per day also when you get to that level, but there are some benefits of alcohol. We know cardiovascular benefits for moderate consumption and the type of red wine, but with the use of insulin, we need to be very particular and very cognizant that they can experience a delayed nighttime or early morning fasting rise because of ingestion of alcohol the night before. So making sure that you're educating on that aspect during these holiday seasons. Next slide. So a couple of things that I just kind of wanted to go to and I utilize in my practice is about mealtime insulin and about meals in general. So we talked about eating and that type of thing. So just a quick blurb on how I would necessarily dose for mealtime insulin. One thing is remembering about dosing prior to meals. I get a lot of referrals that patients dose after they eat their meal. Remember, Humalog has and Novolog both have somewhere between a 6 and 15-minute onset of action. So you actually want to give it before the meal. Regular insulin, if they're on something like that, the insulins from Walmart that are over the counter, those take a little bit longer, so they should actually give even sooner or earlier prior, maybe in the preparation of their lunch or their breakfast. So to dose, I think people get afraid to do that because they think they're going to go low, but just reinforce and educate that it takes that long for the insulin to get in and be there. So dosing prior to the meal is not at the end of the meal, not 30 minutes after the meal, is something that should be encouraged. The other thing I get sometimes is that people dose just on a sliding scale. They don't give them a mealtime insulin dose. They don't say every time you eat breakfast, you take 5 units. They'll say every time check your blood sugar before you eat. And if your blood sugar is 180, give 2 units. And if your blood sugar is 250, then give 4 units. And if your blood sugar is 300, then give 6 units. That's just a sliding scale. That's not, you're kind of waiting for the hyperglycemia to happen, and then we're treating in a retrospective way. You'll struggle getting people's A1Cs better because they go high, because you didn't dose for the actual food that they ate at the time they ate it, and therefore hyperglycemias will ensue. So giving mealtime doses specifically to type 2s, that you say at breakfast you have this insulin, and then you can add that sliding scale. Say, hey, your blood sugar happens to be high. Then you can kind of correct, especially at like lunch or dinner. Their blood sugar kind of went high over the day because they ate a little bit more than they normally do. Then you can give a sliding scale to kind of help fix it. But to just dose on a sliding scale before each meal is not recommended, and you're going to struggle with A1C lowering. Carb counting is a great way. That's where your medical nutrition therapy, and that's where your registered dietitians will come in and be able to educate patients on how to carb count. It is best to carb count for type 1 diabetics, but even some type 2s, you can't flat dose them, or they don't want to flat dose. They know that today I'm going to eat a salad and tomorrow I'm going to have, a more of a pasta dinner. So they want to have different types. So sometimes type 2s can also carb count. But that is definitely a proactive way of dosing mealtime insulin. If you feel like your patients cannot carb count, that it's too taxing and too much math and they don't have the apps to be able to look it up and they're not going to devote the time, then also consider dosing based on their type of meal. So is it a slow carb meal? Like they always have eggs for breakfast. Or is it a moderate type of breakfast and they have, let's say, just a cereal or an oatmeal? So you can dose on the days that you eat eggs, you're going to have 4 units for breakfast. And on the days you're going to have cereal and oatmeal, then you need to have 6 grams. So that's a way. And larger meals tend to be at dinner time. I always ask my patient, what's your largest meal? And sometimes their largest meal could be lunch, but it could be dinner. So just saying, hey, 6 units for every meal you eat is sometimes not that individualized plan. So talking to your patient and figuring out, when do they tend to eat more carbs, and can I give more for their different meals that they're on? So, and that leads into number 5, recommend dosing for all meals, which would be 3 times a day, but many people don't eat 3 meals a day. So then maybe consider dosing for breakfast and dinner, and then at lunch, they barely eat, they just have cheese and crackers, so then we only give them 2 units for lunch. So that's using those individualized meal plans to help also dose them for their meal times. Advise not snacking after midnight. That's just an overall, or after midnight, after 9 p.m. That's just an overall good, healthy aspect. That's not really a diabetes thing, but it will improve your fasting blood sugars. If you don't have patients eating at 10, 10:30, 11 o'clock at night, they'll wake up with improved fasting blood sugars and hopefully some weight loss because they're not snacking in the middle of the night. And then most, you do not need to cover with a sliding scale at bedtime for most type 2 diabetics. I periodically have patients that say, well, if my blood sugar is over 200 at night, I give whatever number of units. Just so that's risking potential hypoglycemia. That insulin is going to peak. You know, if they give it at 11 o'clock, it's going to peak somewhere around 3 or 4 in the morning. And they have not eaten because they are going to bed. So most don't need a coverage scale at bedtime. Some of our type 1s absolutely do, but not necessarily with type 2s. So be very cautious in that. And then also another way to visualize your eating plan is also restaurants. So you know, I have patients that I'm like, every time you eat pizza, you're going to give this dose because it just goes crazy. I had a Chinese man, and he ate rice for every single meal, and he was willing to give it up for breakfast, but had it for lunch and dinner. So we had basically 1 cup of rice, you add 2 units. If you have a cup and a half, you're going to add 3 units. And then for your rest of your meal, it's this. So we actually had a portion, an insulin dose per cup of rice. And then the rest of his meals were, 5 units for lunch, but he ate a cup and a half of rice. So he was going to put a +3 on it. So that's really working with your patients and their meal patterns and what they like to do. And you'll see better improvement in blood sugar control and less risk of hypoglycemia when we really investigate what are patients eating and when are they eating and how much are they eating. And that takes a lot of time. So it's not something that you get in the first visit, but it's over time working with your patients and getting those blood sugar logs so that you can see what times of days are they having trouble managing their sugars. So those are just a few tips that I felt like outside of the consensus report that might help during the holidays and COVID when people are eating really too much. It's the convenience factor, but that's all I have to add. My next slide is just the consensus report that I utilized. It was in Diabetes Care May of 2019.
Thank you so much, Melissa. That was all extremely helpful information, super timely, like you said, during COVID and especially the holiday season rolling around. So, and I personally didn't know all of that about, all of that, but especially the sweet peppers that you mentioned. So that's extremely helpful. Thank you. Did anyone have any questions for Melissa or comments? Feel free to unmute and
I was going to say, does Ms. Smith have anything to add as a registered dietitian?
I was wondering if you had any considerations for patients with gastroparesis that you could share.
Yes, I did avoid that like the plague. It was not necessarily, I just had to cut it off at some point. But gastroparesis liquids, I think you probably know that. So trying to get patients just to get those bite sizes down, but they tend to eat all day, so they're very difficult to manage. Sometimes trying to get them a little bit more on long-acting insulin at the most, about 60% of their dose, utilizing less insulin around their meals so you don't risk. Most of our significant ones that it seems like a lot of my gastroparesis are on insulin or insulin pumps. Insulin pumps tend to do well for gastroparesis, but insulin injections tend to be at the last bite of their meal is when they actually would dose the insulin. So I sat there and promoted all this 15 minutes before. They are one of these patient populations that we would want to dose at the very end of their meal because of the paresis and hanging around longer. We don't want it there too soon, and then it's there, and then the food's still there, and it ends up in rebounding issues of hyper and hypoglycemia. So most of the time, if it's an insulin delivery through injections and or an insulin pump, it's dosing at the end of the meal instead of the start of the meal. Getting them on longer, or not longer, but higher dose of long-acting insulin because food tends to hang around longer. Does that answer your question? That's
It does,
the quick,
yeah.
short visit. I like Ensure a lot on these patients. They don't necessarily like it, but trying to get one meal during the day also just to be an Ensure meal, because it is liquid, it's nutritionally sound, and it sometimes can help prevent some of that hyper and hypoglycemia.
Do you prefer it over Glucerna?
I said Ensure, I mean Glucerna.
Okay.
Yeah.
That was going to be my question. Is like, are you really brand specific here?
No, really Glucerna more so. I have some people that also will utilize Boost because, yeah, it's a Boost. What are the chocolate packets? Yeah, it's Boost, not Boost. What are the Carnation? Yeah, the Carnation stuff. It just, those are higher in carbs, so it really depends on, you know, the sensitivity and stuff like that. Cost of those products tend to be my biggest problem, is people can't afford them.
Right.
Awesome. Thank you both so much for the comments and questions. Anything else anyone would like to share with the group? All right. Well, thank you all so much for joining us today. I'll give you guys about 13 minutes back to your day. And thank you so much, Melissa, for your time and the awesome didactic. I will be posting it on our YouTube page. So I know some folks couldn't join us live today. So I'm sure they'll check it out on our YouTube page. But a couple housekeeping announcements before we part ways. I can't believe I'm saying this, but today was the last session of 2020 for Endocrine Echo. So our next time we'll be meeting will be on January 13th. And Dr. Giordano is going to be discussing some of the diabetes guidelines. So just keep an eye out for that reminder. Anytime throughout the holiday season you need to reach out, just feel free to shoot me an email, and please continue to submit any cases or questions through the online case submission form link that I send out as well. So thank you all so much, and I hope you have a wonderful rest of your Wednesday. Thank you. Bye.
Thank you. Bye-bye.